Hello. I'd like to welcome you to our program, Severe Asthma, Update for Clinical Management and Key Considerations to Target Optimal Patient Care. I'm Dr. Ray Panettieri. I am Vice Chancellor for Clinical and Translational Medicine and Professor of Medicine, a practicing pulmonologist from Rutgers University. And I'm really pleased to be joined with my colleague, Stan Fineman. Stan?
Well, thanks, Ray, and hello, everybody. Good morning. I'm in Atlanta, and I'm an adjunct associate professor of pediatrics at Emory University, and I'm also in private practice at Atlanta Allergy and Asthma.
Great. And our next, you can see below, there are disclosures, none of which I believe impact on our presentation for today. In our discussion today, we have several learning objectives, and we want to apply available guidance to the diagnosis of patients with severe versus difficult to treat versus persistent uncontrolled asthma. Those are confusing terms. Hopefully we'll give you clarity. Identify the biomarkers that define the types of severe asthma and utilize results to classify patients with severe asthma. We want to develop precision rather than personalized, really precision treatment plans for patients with severe asthma that are consistent with current guidelines and evidence-based recommendations. Identify the comorbidities that have an impact on the treatment of severe asthma and discuss treatment strategies and describe strategies for the prevention and treatment of COVID-19 in patients with severe asthma.
Let's start today with a brief discussion of what severe asthma is and why it's emerging as such an important topic for those of us who care for patients with asthma. So one of the things that has been troubling me is that identifying those patients who have severe asthma and differentiating them between those who are just really not controlled because they may not be using their medicine. But clearly, the ones that I describe or I sort of label as severe asthma are the ones who have more persistent symptoms or are the ones who have frequent exacerbations. In other words, they end up coming to my office frequently, or they end up in the hospital needing a lot of steroids. And those are some of the things that I see. And Ray, maybe you could put in, tell us what how you identify that.
Yeah, I completely align with your concepts there, Stan. I mean, we struggle. And actually, let me step back and say, the recognition is the vast majority of patients are uncontrolled. I mean, that's humbling, given the fact that we have an enormity of new therapies, monoclonals, and all approaches. But most of our patients, as defined by guidelines, continued symptoms, use of short-acting bronchodilators, exacerbations, are really uncontrolled. We need to do better. One of the greatest concerns I see as a pulmonologist taking care of severe asthma is the use of systemic steroids. Oral corticosteroid burden is incredible. Patients want to get off steroids, but as they taper, they have a flare or they have symptoms, so they have to go back. Do you see OCS burden as a major problem, Stan, in your practice?
Not really in my practice. I think I see more frequent use or of higher dose inhaled steroids or higher dose combo inhaled steroids and LABAs. In other words, they'll go to their primary for a flare-up, and they'll get a higher dose, and frequently they don't take it regularly. I mean, I know, I totally agree with what you said, and I know that's what the literature says, that even most patients don't recognize that they're not well controlled, and that's a big concern.
Yeah. The other hurdle is really the notion that asthma is a chronic illness that can't be cured. And because it waxes and wanes, when there's no symptoms, the patients naturally jump to the point of taking a drug holiday, right? My asthma is under great control. Maybe I've outgrown my asthma. Now at 63, it's not likely you're going to outgrow your asthma, but people hope, right? And we see that phenomenon over and over again.
No, that's
Right?
very true. I mean, I can't tell you how many times patients come in and they say, "Well, I don't have to use my medicine because I feel good." So it's the same. It's the same thing that we see, over and over. So
Yeah.
I think we've got some interesting slides to show, and so it's my role here to say to. Oops, wait a minute. I got to share my screen first. Hold on a second. I got to share my screen so that so everybody can see the slides. So just give us a second to hear this little technical thing, and then in just a second you'll see this slides. And
Well
oops,
done.
well, there we go. Now it's wait a minute. Now it's in presenter mode. So now we're all set. Okay, Ray, you're next.
All right.
Or
So,
no, I'm sorry. I think. Oh, do I
yep.
present this slide? I'm sorry. I
Yes.
present this slide just to
Stan,
try
why
to
don't you?
define. Un,
Yeah, why don't you go through the uncontrolled, difficult to treat, and severe asthma, Stan, if you'd like.
Sure. Okay. So these are the differentiating factors: the uncontrolled, the difficult to treat, and the severe. And as we were saying earlier, the uncontrolled, which is really most of our patients are uncontrolled, they don't have good symptom control. They have frequently trouble with their walking, or they wake up at night, and they have exacerbations at least 2 times a year, frequently requiring steroids. So that's one aspect of asthma. Difficult to treat is in a different category, and this one is really they're uncontrolled despite their step 4 or 5 treatment according to the GINA guidelines, the new guidelines, which we're going to talk about more in just a few minutes. And then the severe asthma, and they're the ones who are just difficult to control despite even taking their medicine well. They have good adherence. They've optimized their therapy, and really we're doing everything we can, and they still are not controlled. And that's probably a very small percentage, in my experience, maybe around 10% of the patients, but still it's a big problem. So I'm going to turn the next slide over here for Ray to be able
Ray,
to
great.
present. Go
Thanks,
ahead, Ray.
Dan. Yep. Thanks so much for distinguishing severe asthma from difficult to treat asthma. And they're confusing terms, let's be honest. But I think as we develop this theme, you'll get a better sense. So, number one, absolutely, single most important thing is confirm the diagnosis. When you treat for asthma and patients don't get better, one needs to really confirm you're treating the right disease. I mean, it seems obvious, but we can be led down the garden path. We have to confirm airflow obstruction. That's usually with spirometry. And is there reversibility, or is there complete irreversibility? If the patient has normal pulmonary functions and lots of tests, that's where I want to confirm, maybe with a methacholine challenge, as to whether they do indeed have asthma, because you want to show A, reversibility of airflow obstruction. That could be in part, doesn't have to be complete. And B, you have to show airway hyperresponsiveness. Next slide. Let's now develop that theme. And once you have confirmed the diagnosis, adherence becomes an important aspect. And I would say that our adherence to therapy for asthma is not that great. Most patients are non-adherent. I think we see that over and over again. And the vast majority are not using. They are not using their inhaler correctly. So reinforcement of inhaler technique is important, and observing adherence, whether that is by demonstrating script at least refills if one has access to a pharmacy benefits manager program, that would be helpful. But again, we need to reinforce the need for chronic therapy. Now, even when you do adherence measures and correct inhaler technique, maybe patients are unresponsive because their asthma is fundamentally different. Next slide. Identify risk factors and comorbidities. So you've confirmed the diagnosis. You've confirmed adherence and correct inhaler technique. Why is my patient difficult to treat? Why is this a severe asthmatic? Well, there are other concepts you need to keep in mind. Number one, comorbidities really do affect responsiveness to therapy. Is the patient a smoker? Smokers will get smoking engenders a relative steroid insensitivity. Beta blockers in the older patient population with comorbidity of hypertension could affect responsiveness to beta agonists as well as other issues. So comorbidities, and we're going to come back to that, are really important as predictors of difficult to manage and often apparently unresponsive asthma. Next slide. Now, as we go through the confirmation of diagnosis, the adherence that we talked about to therapy, decreasing obstacles to treatment, and then looking for comorbidity, I personally really want to assess the asthma phenotype. Now, there are 3 biomarkers that I think are critical in the characterization of the phenotype, and we're almost transitioning to endotype, that is the mechanism by which asthma can occur. So what are those? Number one, ask, does the patient have blood eosinophils greater than or equal to 150 cells per microliter? Suggests an eosinophilic phenotype. FeNO, greater than or equal to 20 parts per billion, very important. Exhaled NO is a marker of airway inflammation driven for the most part by IL-13 and IL-4. So we want to know, is this patient experiencing ongoing airway inflammation, and B, is that being contributed to by a IL-13, IL-4 signature? Sputum eosinophil is a very useful measure, but to be frank and honest, I don't have the time to do sputum eosinophils, so I'm really not going to be measuring it. Now, you do want to know, though, is the patient allergen driven? So that triad of biomarkers, eosinophilia, exhaled NO, and serum IgE, and more importantly, specific IgE, will give you a sense of whether the patient is atopic, non-atopic, eosinophilic, non-eosinophilic, or has ongoing inflammation. So again, skin positive testing, very helpful. That aligns with immunocap testing. And then you want to ask, is the patient OCS or oral corticosteroid dependent? Now recognize oral corticosteroids will change some of these biomarkers. So as you're measuring them, if the patient's on systemic steroids, that's going to impact on the eosinophil count, can impact on the FeNO measurement. So keep that in mind. It has a little less effect on specific IgE, but of course chronic steroids could even modulate that outcome. So in every patient, first visit, you want to know these biomarkers are positive, negative, and what is the contribution of atopy and allergy to the patient. Stan, back to you.
Well, thanks, Ray. Yeah, and as a matter of fact, I'm going to stop sharing the screen for a minute because you bring up a very important point about how important eosinophils are, and now wait a minute, I'm having troubles getting back. There I am. So how important eosinophils are to try to help us decide how we're going to treat these patients. And I think what you said about identifying these markers early on when you first see the patient can really help and help us decide how we should manage the patient and go from there. I'm going to share my screen again. There's a few slides that I'd like to show you that are important for this discussion. So here we are. This was Ray's last slide, and this is what I wanted to point out here. The next few slides are covering its topics of eosinophilic granulomatous with polyangiitis. And in fact, Ray, I think were you planning to talk about these?
Yeah, let me take these slides, Stan, and round out this conversation around eosinophils. So we set the stage, right? these three biomarkers very important. But what about the patient who has a robust eosinophil count and seemingly is steroid dependent? You give steroids, the EOs go down, but they come right back when the oral steroids are taken or tapered off. So what are the comorbidities that one needs to be aware of? Well, one of those is eosinophilic granulomatosis with polyangiitis. Now, many years ago, this was referred to as the Church-Strauss syndrome. More accurate, though, is the eosinophilic granulomatosis with polyangiitis. Now, I'm going to call that EGPA. Now, what are the characteristics? Well, you got to have asthma, eosinophil counts that are very high, greater than 10% total, and systemic consequences. So there we're talking about neuropathy, non-fixed pulmonary infiltrates, or what we call fleeting pulmonary infiltrates, paranasal sinusitis, extravascular eosinophils, ANCA positivity. So got to keep this in the back of your mind. It's not a common disease, but it's a devastating disease when it's not recognized, and it is systemic. Next slide. So when we talk about this, there are stages of EGPA. The prodromal allergic phase is going to be just like difficult to treat asthma. It is asthma, it's AR, allergic rhinitis and sinusitis. But then there's a transition to the eosinophilic phase where you get a robust peripheral eosinophilic and now tissue infiltration and invasion. And at that point, the missing of the diagnosis and then the progression to a systemic vasculitic phase could be devastating. You have neuropathy, palpable purpura, necrotizing glomerulonephritis, with or without crescent formation. And again, you're talking about now impaired renal function because of the systemic nature of the eosinophils. So keeping this in mind and keeping the eye on what else could be going on is very important. Now, there are other masqueraders of asthma. Next slide. And this is hypereosinophilic syndrome, or HES. Now, this we can discriminate from EGPA in the fact that it's uncommon for hypereosinophilic syndrome to present as asthma. It is uncommon. Now, asthma is a common disease, so there will be some overlap at some point, but it's a rare blood disorder. Lots of EOs for greater than 6 months, chronic and progressive in nature. There's the myeloproliferative, lymphoproliferative, and an undefined component. There is eventual organ dysfunction, but what's not prominent here is a lot of asthma. So this could be somebody who may have been misdiagnosed and is developing secondary organ dysfunction, but asthma is not the prominent player. Next slide. Now, how do you evaluate hypereosinophilic syndrome? Well, again, if you have sustained EOs that are high for greater than or equal to 1 month with pathologic tissue hypereosinophilia, that is the sine qua non of HES. Now, look for symptoms: skin rashes, angioedema, dizziness, some confusion, memory loss, maybe cough, maybe shortness of breath, fever, mouth sores, and so forth. But not there is asthma. So if the patient has really not apparent asthma, not a lot of wheezing, not chest tightness, then I would be really focused on HES. And then you're going to look for abnormalities or T-cell clones, eventually making the diagnosis. So we talked about EGPA, we talked about HES. What else? Next slide. And that is chronic rhinosinusitis. Now that comes in several flavors, right? There's chronic rhinosinusitis with and without polyps. This comorbidity can walk hand in hand with asthma. So again, discriminating it from HES, that's not going to be a prominent component here, but could be confused with EGPA. Health impact, there's a ton. Sleep deprivation and loss, productivity, quality of life is markedly is impeded. Risk factors, more common now here in males than females, and there's no strong link to specific genetic or environmental factors. 20% of CRS patients will have nasal polyps. A nasal polyp biopsy is helpful and establishes the eosinophil as a major player, requires long-term medical treatment, particularly difficult to treat, may require surgery. However, the excitement around monoclonal antibody therapy is that some of these therapies are clearly impacting on nasal polyp generation and progression, and even in chronic rhinosinusitis. So we have optimism as we move forward that some of the monoclonals may actually really impact on this disease. Next slide. So the evaluation of chronic rhinosinusitis with nasal polyps, the symptoms are anterior posterior rhinorrhea, nasal congestion, hypoosmia, as well as facial pressure that occurs frequently and sustained, maybe over as long as 3 months. The nasal polyps are pictured in the rhinoscopy photomicrograph on the right side. You can see particularly large nasal polyps, maybe benign or malignant as shown in the bottom, but it really does require a fastidious evaluation. Now, I, as a pulmonologist, don't routinely do rhinoscopy. My allergy immunology colleagues do, as well as ENT. So at that point, I would be referring the patient to A, make the diagnosis, and B, help me in the management of chronic rhinosinusitis with nasal polyps. Next slide. Now, once we've made the diagnosis of asthma, confirmed adherence, reevaluated inhaler technique, and evaluated concomitant illnesses, we now move on to treatment. So what is the management and what's the cornerstone of the management of asthma? Well, reliever medicines are important. Short-acting bronchodilators, beta agonists for the most part, are critically important as reliever medications, as well as short-acting anticholinergics. Now, for the patients with severe, moderate to severe asthma, difficult to manage, you're always going to have these people, these individuals on controller medications. I particularly like ICS-LABA out of the box. I may or may not add leukotriene modifiers as ways of modulating the controller use, also potentially to hit areas that the steroids won't hit. Add-on controllers after you've agreed that the patient is adherent, that they're using their medications. You may now want to move on, if they're failing therapy and are difficult to manage, to a long-acting anticholinergic. There are a variety there that are effective, but I would then start to consider targeted biologics. My goal with the targeted biologics are simple. I want to spare oral corticosteroid use. I want to eliminate 0 exacerbations, and I want to improve quality of life. But my goal with the use of these targeted biologics are quite focused, and I need, if starting a biologic, to have shared decision-making with the patient. The patient needs to buy in and understand, when am I going to switch this therapy? What are the metrics of success? Now, after all that, you still have the refractory patient. Maybe they didn't qualify for biologics. Maybe they are a low T2 inflammatory patient. There we may consider macrolides on a Monday, Wednesday, Friday schema. Low-dose macrolides are anti-neutrophil drugs. They can also enhance the efficacy of steroids. And in some patients, I have done and had success with bronchial thermoplasty. But the nature of bronchial thermoplasty is that the vast majority of those patients have already failed conventional therapy. We've not seen large improvements in the FEV1 with bronchial thermoplasty, although we have seen the ability to decrease exacerbation rates. Next slide. So, what are our targeted biologic therapies for severe asthma? It has never been better to be managing severe asthma as today. What we know is that we have 5 biologics to treat asthma. We have one that is solely targeting IgE, omalizumab. It has been around for some 17 years. Pretty surprising. 17 years. It's indicated for greater than or equal to 6 years old. That's positive skin test and reactivity perennial aero allergens are necessary. Very useful, and it's a sub-Q dose. And we have 3 anti-IL-5 drugs, 2 that target the ligand, that is mepolizumab, rezolizumab. Mepolizumab now around for 5 years, rezolizumab a little less, but that's the only IV formulation available, dosed according to BMI, and benralizumab, which is uniquely targeting the IL-5 receptor. And when bound, it actually heralds cytotoxic killing of the eosinophil, eliminating the eosinophil. So 3 anti-IL-5s, all very effective at decreasing the eosinophil counts, which then become a pharmacodynamic biomarker that you've engaged the target. Dupilumab is the sole drug that targets the IL-4 alpha receptor. And remember, the IL-4 alpha receptor integrates both IL-13 and IL-4, eliminating the activation of both of those the cytokines on the IL-4 alpha receptor. It is the only drug really approved for nasal polyps at this point, as well as severe asthma. It is add-on for patients greater than or equal to 12 years old. So that is the repertoire of currently available monoclonals. Tezepelumab, an anti-TSLP monoclonal, is in phase 3, should read out in the next year and may be available. Reason that's important is TSLP is an alarmant, much like IL-13 and IL-25. It will be our only drug targeting alarmins, which are high in the upstream pathway liberated by epithelium. So it is an intriguing monoclonal. It is not available currently, and it is still in development. Next slide. So type 2 severe asthma considerations as add-on. Make sure the patient's adherent. Increasing the ICS for 3 to 6 months is useful. Consider aspirin exacerbated respiratory disease, so-called triad asthma, ABPA, chronic rhinosinusitis, we touched on, nasal polyposis, atopic dermatitis. Add the biologic and consider one of the following if there's no resolution. Maybe higher doses of ICS, if not used before. I found that not to be particularly useful. Non-biologics, we already touched on that. We could try and modify it. Maybe macrolides, maybe LABA. Stopping ineffective therapy. Need to kill drugs quickly and then move on. And low dose OCS strategies to minimize side effects. Next slide. Consider biologics. Patients have exacerbations or poor symptom controls. If local payer eligibility criteria met, then I would swiftly go to that therapy, as well as considering predictors of response, costs, and dosing. All right. Stan, I think you're up.
Well, thanks, Ray. Yeah, that was great. And now, of course, so we have our patient who's not well controlled, as Ray described. Now we've got to make a decision about what biologic we're going to add on. And so let's just review quickly the types of biologics that can target your type 2 asthmatic patient. So let's look at the IgE. So anti-IgE, first of all. As Ray mentioned, omalizumab is the one we have available. Is this patient eligible for a biologic? First of all, they have to have a specific IgE. They have to have allergies. So they need either a immunocap that's positive or a specific skin test that's positive, allergy skin test. The total serum IgE and the weight have to be in a specific range, and they certainly should have certain number of exacerbations per year. Now, is the patient likely to have a good response? It seems that looking at the studies, that patients who have higher blood eosinophils and also higher exhale nitric oxides, and the ones who have allergy-driven or asthma, allergic asthma, and even those who started having asthma in childhood seem to have a better response to the anti-IgE or the omalizumab. In fact, now we can use it in children, as Ray mentioned. So let's look at the next group of options for biologics targeting type 2, the anti-IL-5 or IL-5 receptor antagonists. Again, we have 3 of those available. How do you decide if the patient's eligible for a biologic? Well, the number of exacerbations they've had, and also looking at the blood eosinophils, you want to see a total eosinophil count of 300 or more. And is the patient likely to have a good response? Well, the studies indicate that those who have higher blood eosinophils tend to respond better to the anti-IL-5 drugs. The more exacerbations in the previous year, and adult onset asthma and nasal polyposis. We've had some patients who've had remarkable improvement with the anti-IL-5 with high eosinophils and even with nasal polyposis. Let's look at the third option. Here, this is the IL-4, the IL-4, IL-13 antagonist, dupilumab. Which patient is, really the best one who's going to have a good response for that? Well, we look, number one, is the patient eligible for a biologic? They have to have eosinophilic type 2 asthma. They have to have a certain number of exacerbations per year. We say at least 2. Oops, I clicked ahead. They need to have blood eosinophils a little bit lower. Exhale nitric oxide, we like to see it elevated. And they may need maintenance oral steroids or every other day systemic steroids to control them. So these might be candidates for a biologic, and we would look to see them have a good response with an IL-4, IL-13 dupilumab type antagonist. If they have high eosinophils, very high exhale nitric oxide, that seems to be a good biomarker for these patients. The anti-IL-4 receptor can also be used to treat atopic dermatitis. In fact, that was the initial approval for dupilumab was for atopic dermatitis. Now we could use it even in 12 and older. And nasal polyps, it's just been approved recently for nasal polyposis, and we've seen dramatic improvement, especially with the hyposmia in patients who've had nasal polyposis when they've started on their IL-4 receptor antagonist, dupilumab. So let's look at when are we going to switch therapy. So we have a patient, we have severe asthma, we've given them this option for a targeted therapy. I like the fact that Ray mentioned that we do the shared decision making. I think that's very important. Patients have to want to go ahead and take these treatments to be more compliant. So how do we do it? Okay, so first of all, we're going to do a trial for at least 4 months to assess the response. Okay, do they have a good response? Well, if it's not sure, we might continue it for another 6 to 12 months if we think it might be a good patient for this product. Otherwise, if they have a good response, obviously we're going to reevaluate them every 3 to 6 months. We bring them in the office. We do, as Ray mentioned, spirometry, do exhale nitric oxide. We look to see that they're reducing their oral steroids. We look at their inhaled steroids. We hope to reduce, their dose of inhaled steroid. And then we reevaluate the need for an ongoing biologic. We do their spirometry, exhale nitric oxide, as I mentioned, and we look for reduction in treatment based on the benefit, clinical benefit, some of the side effects, cost, and also patient preference. So these are some of the decisions that go into the patients who are on a biologic who are having a good response. But let's look at the ones who don't have a good response. Okay, so that's some patients, even though we think it's going to be a good option for them, they may not. And so if they don't have a good response, then we may need to think about changing it. Even after about usually I'll give them about 4 to 6 months. We might stop the biologics. We go back to basics. We reassess their phenotype, their total, their eosinophilia, their specific IgE maybe. And you want to stop the add-on therapies. You definitely don't want to stop their inhaled steroid. But, what I usually, in fact, I tell patients is, look, things are not working. I'm going to pretend you're a brand new patient, and we're going to go right back to basics and start at the beginning and make sure we haven't missed anything, because that's really, really very important. So
Right.
let's talk about these other options. And I think, Ray, if you could take over now.
Yeah, I'll take over, Stan. Great job on the high T2 therapeutic approaches. Of course, now Stan leaves me with the low T2 severe asthma, and I can uniformly say we don't have a whole lot of therapy in this space. So high T2, we got lots, but in low T2, we really don't. Number 1, 2, and 3. Differential diagnosis, again, back to basics, as Stan mentioned, really important. Know the patient's taking their drugs, be sure that they have access. Other common factors: cigarette smoking, gender steroid insensitivity, smoking cessation is critical. Allergen avoidance, as well as the irritants. Irritants here are going to be more like pollutants, ozone, sulfur dioxide. Consider a high-res CT scan. I personally do that in all my severe asthmatics. I'm looking for concomitant illness that can masquerade as difficult to manage asthma. You could consider bronchoscopy or sputum induction. I don't tend to do that unless patients are on specific protocols. As we talked about in the low T2 group, I would give tiotropium. Clearly can decrease exacerbations, improve objective measures of airflow. I consider macrolides, low-dose OCS to determine whether they are steroid or non-steroid responsive, and then stop ineffective therapy and consider bronchial thermoplasty. Next slide. So, as I had alluded to, there's these comorbidities that are important. The good news is the anti-IL-5s are being investigated in chronic rhinosinusitis with nasal polyps and EGPA and in hypereosinophilic syndrome. And MEPO has been approved for EGPA. Others, as you can see here, are in phase 2 or phase 3. The only one approved right now for nasal polyps is dupilumab, although the other anti-IL-5s are currently being examined. And dupilumab is looking for the indication in hypereosinophilic syndrome. Next slide. Well, we would be remiss if we didn't bring up COVID-19. How has COVID-19 impacted asthma? Well, surprisingly, the data suggests that our patients have done better in the pandemic. But there are some very important caveats. I do not stop biologics, and I even start biologics at times if patients are poorly controlled. But what we've seen is the quarantining and the wearing of masks have decreased, I think, viral transmission, not only to SARS-CoV-2, but to other viruses that would exacerbate asthma. It's also decreased trigger exposure, remediated triggers. People staying at home and practicing good hygiene and social distancing has diminished triggers. We've seen a huge uptick in adherence. People started to take their medication as prescribed. Some of this may be for fear that they were going to have problems. Of course, with your steroid use, you want to be careful in this current day and age to start steroids or high-dose steroids unless indicated for an exacerbation. Now, the data has been interesting that dexamethasone's actually been useful in the management of COVID-19, especially those with the most severe. But I haven't changed my management much. The basics are still imperative. Stan, what's been your experience with COVID and asthma?
You know, it's interesting. I totally agree with you. We really encourage our patients to continue their maintenance medications, especially their inhaled steroids. In fact, I know that there have been some folks suggesting that using inhaled steroids might even have some protective effect for some of these patients that get the COVID virus. That's still, I think being researched right now. But I think that you're right. I don't think that people are getting as many other types of respiratory viruses, rhinoviruses that might be triggering upper respiratory, and respiratory illnesses. And they're certainly more compliant. And I think that's a problem. I'm sorry, that's an improvement of things. The problem that we've had in our office is the challenge of doing spirometry and exhale nitric oxide, since it's a procedure that people blow into the device, and they can scatter particles. For some of our offices, we have a number of offices. Some of them have had a challenge in protecting the staff and the patients. So we've reduced a little bit some of our use of spirometry. I don't know about you guys in your
Yeah,
facility up
yeah,
there.
Stan, that's been a real struggle because we're looking to use these effective tools for following patients, but we have to be cognizant that a forced expiratory maneuver will aerosolize a lot of particles. I'm optimistic that in the future we will have vaccines, but also point of care testing that will give us answers within minutes, not days. And that might allow us then to reestablish objective measures of airflow, aka spirometry and pheno, which we find so valuable in the management and following of asthma. Well, we have covered a lot of real estate here. We have gone through pathogenesis, comorbidity, current therapies. And this does bring the discussion almost to a close. I'd like to summarize that many patients with asthma continue to report severe uncontrolled disease despite treatment. A little tidbit here is our exacerbation rates leading to emergency rooms since 1970 have not changed, despite the fact we have the best therapies ever. We improve outcomes in patients with severe uncontrolled asthma. We should use precision approaches or personalized approaches, identifying every patient as a snowflake and treating them in that precise manner. Broad range of non-pharmacologic, pharmacologic interventions are now available, especially in the high T2 space. We have options. The low T2 space, we are still struggling to find a precision approach. And the pandemic has changed the life as we know it. But for our asthmatics, interestingly, they have done somewhat better by reinforcing the basic tenets of trigger remediation and adherence to therapy. I want to thank you all, and I want to pass back to Stan for any final comments before we turn over the program. Stan?
Thanks. Yeah, so we're back live. Yeah, no, first of all, I think it's been a great opportunity. I love the way, Ray, that you described this as a wonderful time for treating asthma. We have a lot of good options for treatment, especially the Th2. The challenges that we have is deciding which patients are candidates for which particular product. That's a challenge I think everybody's facing. We have no head-to-head studies comparing the different products, but I think as we get more experience using the different products, and as we see the long-term research come out with the data showing which patients are more likely to respond, I think that we can make wiser choices of which patients should be receiving these biologics. But I appreciate the opportunity to talk with everybody today, and I'm going to turn it over to Ray for some closing remarks.
Thank you so much. Remember, we highlighted throughout our talk shared decision-making. We as providers want to make our patients feel better, but we have to have a partnership with them. So please ask the patient, what type of therapy would you like? We have options. We can do sub-Q, we can do IV, we can do every 2 weeks, we can do every month. Some that then go to every 2 months. So involve the patient and will likely improve adherence. I want to thank the audience for sharing a Saturday. I want to thank you for joining us. Please claim your CME credits by completing the post-test evaluation at integrityce.com, Asthma Post. And I really want to thank you and have a great balance of your weekend. Stan, always a pleasure, my friend. Have a great day.
Thank you. Bye, all.
Bye.